Okay, let me start over. Identification and management of depression in the family practice setting. And with that, I'm going to turn it over to Dr. Goddard.
Okay, thank you. So our objectives today will be to identify screening tools, the pharmacological management, and the clinician's role in evaluating and managing a depressive disorder in the primary care setting, and to discuss methods to recognize suicide risk in a patient. So let's start by looking at the global perspective of depression. Depression is a multifaceted disease that affects a person's physical, mental, and emotional health. It is the leading cause of global disability, affecting approximately 264 million people of all ages worldwide. Depression is associated with a higher rate of chronic disease, substance abuse, and suicide. Depression is more common in an urban setting of developing countries and in regions with military conflict. Now, back in the US, in 2017, an estimated 17.3 million adults in the US had at least one major depressive episode, which accounts for about 7% of all US adults. Of that group, 64% had a severe impairment, which would account to about 4.5% of all US adults. The prevalence of major depression is higher among adult females compared to males in the 18 to 25-year-old age group, and among adults reporting 2 or more races. Risk factors for depression are noted here and include substance abuse, low socioeconomic status, a history of foster care or adoption, history of abuse, a poor support system, medical comorbidities, a family history of depression, being female with a recent childbirth, the patient having a prior episode of depression. In women with bipolar disorder, episodes of depression or mania are more likely to occur during pregnancy or the postpartum period than at any other time in their life. Having a history of postpartum episode of depression, the likelihood that another episode will occur after a subsequent pregnancy is high. Also, national data from 2017, there were 3.2 million adolescents who had at least one major depressive episode. So that's about 13% of the adolescent population. The prevalence was higher among females compared to males. And again, in adolescents, it reported 2 or more races. Of adolescents with a major depressive episode, approximately 71% had a severe impairment, which would account to about 9% of the US population between the ages of 12 and 17. Adoption studies provide the most powerful method for testing the relative contributions of genetic and environmental factors to heredity by comparing rates of disorders in biological versus adoptive family members. Adoptive studies have demonstrated that significant associations between unipolar depression in adoptees and their biological, but not their adoptive relatives. The Psychiatric Genomics Consortium was established in 2007. It was an international collaborative effort to have a big enough sample size for effective and valid research. There were 27 genetic variants that were identified and implicated in major depressive disorders. So not only do mood disorders likely result from several genes acting simultaneously, but it's also likely that it results from the effects of several genes interacting with one another and then interacting with the environmental factors. But remember, you do not have to have a family history of depression to develop depression. Noted on this slide are some common symptoms of depression among adolescents, adults, and the elderly. So adolescents may present with chronic somatic complaints like stomach or abdominal pain, headaches, general pain syndromes, fatigue. In the adult population, you might see mood or sleep alterations, changes in appetite, fatigue, feelings of guilt or worthlessness, difficulty with concentration or making decisions, and possibly recurrent thoughts of death, suicidal ideation, or even an attempt at suicide. The elderly population may present with somatic complaints more than mood alterations. So also remember that culture and ethnicity may play a role with the expression of the symptoms of depression. It can play a role with the real or perceived stigma associated with psychiatric illness, and it may play a role in treatment preference decisions as well. Deaths from natural causes occur 1.3 times more than expected in the general population, with infections, cardiovascular, and respiratory system disorders accounting for most of the excess risk. Total life expectancy is reduced by 19 years in major depression disorders. So alcohol and drug use disorders may be a complication of mood disorders, and that's particularly evident when a person begins to drink heavily in mid or late life. Alcohol and drug use disorders are not comorbid with a mood disorder. Those usually begin earlier in life. Poor judgment and bad decisions also commonly accompany depressive disorders. Decisions to leave a job, move to a different city, separate from a spouse, may all result from dissatisfaction as a result of the depression. So you may need to advise your depressed patients not to make major life decisions until they're clearly in remission. Cognitive testing in major depressive disorders may show impaired attention with deficits in explicit verbal and visual memory. Implicit memory, like walking or riding a bike, appears to be preserved. Impairment in executive functioning and slowing in the motor and cognitive domains has also been noted. Severity of depression is associated with the degree of cognitive impairment. Several studies have demonstrated that major depressive disorder is significantly related to poor academic performance, including college dropout. In one study at a major university, students who withdrew from school because of depression did not fare as well on their return to classes as other returning students who did not have a history of depression. These cognitive abnormalities are more pronounced in the elderly. The memory impairment with depression can be so profound that a mistaken diagnosis of dementia can be made. And the true identity of the problem is revealed when memory returns to normal after recovery from the depression. This memory impairment owing to depression has been called pseudodementia. Occasionally, depressive symptoms in the elderly can herald the onset of a dementing disorder. So the combination of cognitive control dysfunction in elderly patients along with depression predicts a poor response to antidepressant treatment. Now, making the distinction between grief and major depressive disorder can be difficult. Bereaved patients may present with symptoms of both grief and depression. During the first few months after the loss of a loved one, depressive symptoms are common, and the diagnosis of a depressive disorder may be deferred. A diagnosis of major depressive disorder is appropriate at any time, though, if the symptom picture involves marked impaired functioning, preoccupations of worthlessness, suicidal ideation, or psychomotor impairment. Because depressive episodes are so disruptive, distressing, and costly, and confer increased risk for suicide regardless of the context of bereavement being present, diagnosis of depression following loss of the loved one can facilitate initiation of treatment and thus an improved outcome for the patient. So grief symptoms are not generally responsive to antidepressant treatment, but depressive symptoms in the context of bereavement are. Some barriers to the diagnosis of depression in the primary care setting may be related to time constraints on providers, lack of established screening and diagnostic protocols, possibly higher patient acuity with patients that have multiple comorbidities that the provider is trying to deal with, and simply the myriad and variable presenting symptoms of depression. The U.S. Preventive Services Task Force recommends annual screening to identify depression in the primary care setting for ages 12 and up. Both the American College of Gynecology and the American Association of Pediatrics recommends frequent screening for women in the first year after childbirth. But keep in mind that screening must be combined with patient interview, with treatment, and a strategic follow-up plan. So providers must recognize groups with higher risk and screen those groups at every primary care visit, such as postpartum women, adolescents, adults experiencing high stress, anyone struggling with substance abuse, anyone with serious or multiple comorbidities. So you can very simply use 2 simple screening questions. Over the past 2 weeks, have you felt down, depressed, or hopeless? And or over the past 2 weeks, have you felt little interest or pleasure in doing things? The most validated and widely used depression screening tool is the PHQ-9, Patient Health Questionnaire. It's a 9-item screening tool. It's available in more than 50 languages and includes a modified version for adolescents, which makes it a very versatile tool for diverse patient populations. There is a PHQ-2 that is a shorter version that consists of the first 2 questions, and it can be used as a brief initial screening tool. The Hamilton Depression Screening Scale, or the HAM-D, is a clinician-administered instrument that addresses the presence and severity of depressed mood, anxiety, somatic symptoms, weight loss, hypochondria, insomnia, suicidal ideation, and psychomotor retardation as evaluated by the provider during the patient history and initial exam. The 17-item HAM-D requires about 20 minutes to complete, but there is a shorter subscale, the 7-item HRDS 7, that may be used during shorter patient encounters. The Beck Depression Inventory is another common one, and it is a 21-item self-administered tool for both adolescents and adults to assess symptoms of depression that have been present during the previous 2 weeks. It takes about 10 minutes to complete. There is a shorter version, the Beck Depression Inventory Fast Screen, which is a 7-item instrument designed for use in primary care. It removes the screening items that are related to somatic symptoms. The Edinburgh Postnatal Depression Scale is designed specifically and is very well validated for postpartum women. It omits questions about somatic complaints that are common during the postpartum period, like sleep disturbance, but it does introduce questions about anxiety because depression and anxiety are more likely to occur together during that postpartum period. The Geriatric Depression Scale, or the GDS, is a 30-item screening tool designed to identify depression in the geriatric population. Now, elderly patients are more often likely to experience fatigue, sleep disturbance, or weight loss due to chronic comorbidities or the normal aging process, so questions about those symptoms are omitted from this tool. There's a shorter version with 4 questions that has been developed to reduce test fatigue in the elderly patients that might have dementia, might be frail, might have cognitive impairment. And then finally, the Pediatric Symptom Checklist. The PSC-17 is a depression screening tool designed for administration by a parent, or if it's an older child, they can do a self-administration. And a recent study found that the PSC-17 demonstrates a high reliability and yielded higher rates of detection than clinical judgment alone. So that's a good tool to utilize as well. When evaluating a patient for depression, it's helpful to use the SIGI-CAPS mnemonic in your history-taking interview and ask about, has their mood been sad? Have they recently become uninterested in their usual activities? Any feelings of guilt? How has their energy level been? Any fatigue? Are they having trouble concentrating? Any changes in their appetite? Any psychomotor changes like feeling anxious, upset, irritable, restless, or any changes in their sleep? Any thoughts of hurting themselves or others? A review of 17 studies of suicide found that 15% of patients with major depression will eventually die by suicide. However, the patients studied were severe cases in an inpatient setting and not necessarily representative of all depressed patients, so the actual rate, could be substantially lower. Prior suicide attempts have been found to be associated with subsequent suicide. About 1 out of 20 attempters will be found dead by suicide within 5 to 10 years after an attempt. The period of highest risk appears to be during the first 2 follow-up years and the first few weeks after discharge from an inpatient psychiatric care center represent a time of heightened risk. The medical seriousness of the attempt is a weak predictor at best. Medically trivial attempts are sometimes followed by eventual suicide. Suicide risk appears to decrease after initiation of antidepressants and/or psychotherapy. The risk of suicide is not necessarily correlated with symptom severity. Suicide risk is associated with psychiatric illness, age greater than 65, male, living alone, recent stressors like job loss, or loss of a loved one, access to firearms, a feeling of hopelessness, prior attempts, and communication of suicidal intent. The disorders most frequently associated with suicide are mood and substance use disorders, but schizophrenia and personality disorders are also prominently represented in completed suicides. Among patients with bipolar disorder, a history of suicide in a close family member is significantly associated with suicide risk. The old adage that patients who talk about suicide do not commit suicide is untrue. Suicidal communication may impart increased risk. However, those who are serious about completing the act often do not convey intent to others in their final days. Mortality risk is increased 8 times for patients with major depressive disorder, and most of that excess mortality is from unnatural causes, especially suicide, which accounts for 55% of the excess deaths in major depressive disorder. So some strategies for the primary care provider. If your patient is not at immediate risk but needs additional evaluation, could include calling the patient's therapist in their presence, calling your local or regional MHMR, consult with and get an appointment with a psychiatrist or a psychiatric mental health nurse practitioner, maybe talking with a supportive family member, developing a plan, but be sure to document your actions and the patient's response and agreement with the plan in your medical record. Now, if your patient is at serious risk and you think there is a definite risk of self-harm or harm to others, you need to call 911 right from your office and get some immediate intervention.
Okay, it's my turn. Let's talk a little bit about the brain. The brain is responsible for numerous things. We are looking at, if you look at this cross section here, the anatomy of the brain. The brain is the control center of the body. And when we look at depression, it is going to be multifaceted across the brain. And the reason is the 5-HT receptors, which are the serotonin receptors, especially the 5-HT1, are globally in the brain. So when we have a problem with the receptors not working correctly, then we're going to look at how it's going to affect each portion. So the neuroanatomy with the limbic system, inside the limbic system is known as the emotion control area of the brain. Specifically in the amygdala, we find that as the patient's decrease in serotonin is evident, that they feel like they are ready to die, they have feelings of guilt, they feel like life is not worth living. In the hippocampus, They will also have problems with memory and decreased concentration. So it's very important that we screen appropriately, as Dr. Goddard has reviewed. In the frontal cortex, you're going to see that this is where the depressed mood is going to be the most obvious. The basal ganglia, which are really where dopamine and some of the other receptors are located, will also cause problems like psychomotor agitation, retardation, and in the hypothalamus, appetite loss, loss of pleasure. The most important thing to note is that usually, even though that the research hypothesizes that serotonin is the primary problem in the brain when the levels decrease, causing the depression, but also be aware that this can mean like a cascade response as well. It can also affect dopamine, norepinephrine, GABA, and glutamate. So it's very important that we get an overall evaluation of the patient and make sure that they don't have anything else going on. Now, before we even start saying the patient is depressed, we need to always rule out issues. The first one being substance use or abuse, which is very common in our society. So many times the patient may be what they call an in-closet alcoholic, or they do recreational drugs on the weekend, a weekend warrior type situation. Other things such as medical conditions, diabetes, tumors of the brain, and various mental illnesses may also be affecting what's going on in the brain. Especially in the elderly, medication side effects are a very big issue, and many times they are not picked up by the provider. So it's very important to make sure that we look at the medication side effects and make sure that this is not part of what's going on with the patient. For example, when you start a patient on hormones, such as estrogen or progesterone or whatever, they can have the side effects of being depressed or being hyper or various other situations. So be very cognizant of what's going on with the patient as far as their medications. Always rule out other types of depression or other issues that are going on with the patient. And we'll go more into this in detail, but dysthymia is a type of chronic depression. Adjustment disorder with depressed mood usually relates to children, adolescents. Bereavement, as discussed by Dr. Goddard earlier, can mimic depression, and the way we can tell the difference is that people who are bereaving the death of someone might want to be with that person, but they're not actively saying, "I'm going to kill myself to get there." If they just become suicidal, clear warning that they're more than just bereaving. Then mood disorder due to medical condition, as we just discussed. Postpartum depression, you have to realize that these people, after they give birth, have numerous changes in hormones, and this is very common. Postpartum depression is more common than really is advertised. Then the newer thing that we are looking at now is premenstrual dysphoric disorder, and this is basically when people start having a meltdown, usually around the time of their menses. And then bipolar, always screen your patient for mania before you give them a depression diagnosis. You need to ask them questions such as, do you have periods of time where you feel euphoric, or you go out and you spend money, or do things you would not normally do, have sex with other people that you do not know, those type things, so you can rule out that because it's very important. And there are bipolar screening tools as well. And then, of course, dementia, people who are demented can also be depressed, but sometimes dementia is the primary problem. Okay, so when you are looking at the DSM-5, which has been in existence since 2013, we're looking at least 5 things that we need to have them be positive for. So the first one is we're looking at a major depressive disorder, and that they've never had a manic or hypomanic disorder or episode. When we look at mania, they have to be manic or in the hyper euphoric mood for a week. Hypomania is going to be like 3 days. So it's the timing is very important. You need to rule that out, because if they're bipolar, they need to be referred out. Because if you start giving them actually any type of SSRI, you can cause them to become manic. Okay, and then mood disturbances or anhedonia. Anhedonia is very significant in the fact that it tells us something's going on with the dopamine level in the brain, and so it's a loss of pleasure. And so when they, for example, they used to craft every day, and now for the last month they have not crafted at all because it's no longer a pleasure to them. So that would be an indication that they really might need more than an SSRI, and we'll get to that later. And then they're going to have significant distress in psychosocial or work environments. And then we're looking at sleep alterations, meaning they either have hypersomnia or insomnia. They may be hyperactive psychomotorly, or they may be hypoactive. They may have appetite changes where they either are gaining weight because they're eating so much, or they may be having no appetite because they are so depressed that they don't care if they eat. Energy changes, as we discussed, really kind of comes with psychomotor changes, feelings of guilt, worthlessness, difficulty concentrating, and thoughts of death and suicide. Now, a lot of times people are hesitant to ask, not the patient has suicidal thoughts, because I think that maybe we may push them over in that, but a lot of times the patient wants to talk to you about this. And they'll tell you, yeah, I think about death all the time, but I'm not going to kill myself. It's there chronically. Or they may say, yeah, I have a plan, and this is what I'm going to do. And then you're going to look at that and think, is this plan feasible? So if they tell you they're going to blow their brains out, but they have no access to a gun, probably they're not going to do that, but you still want to follow up with them and do the suicidal screening. And then one thing I want to talk about is smiling depression. This is a characteristic of someone who is depressed, but they don't want anybody to know that they're depressed, and they have learned to adapt socially. So they're always smiling and they appear to be happy. However, underneath, as you can see in this mask up here at the top of the screen, this little, they put their little mask on and they smile and they think they act like everything is hunky-dory when it is not. So be aware to look under the surface if people are too happy or they never seem to have a problem. Okay, dysthymia is, again, chronic depression. A person has to have criteria for this for 2 years, okay, if they're adults. If they are children, they have to have this, the criteria meets for 1 year. So we're going to, when you think about this, it's going to have the same type of characteristics. They're going to have feelings of depression. They have that poor appetite, overeating, the same type of criteria that you're going to find in depression, except for it lasts for a really long period of time. For example, I know people who have never been happy and they're always sad and depressed. And some of those are, I have a relative that is that way. And I just think she has dysthymia. She never has been diagnosed with it, but she's just chronically unhappy. And you can tell by looking at her that she has some of these things, the low self-esteem, loss of energy, and just feels a little hopeless. Okay, adjustment disorder. You're going to see this with children and adolescents. It's within 3 months of an identified stressor. A lot of times children who are abused or have suffered trauma will have adjustment disorder. For example, if they're in a foster care system, if that system is notorious for having dysfunctional children because they usually are passed over and over from one home to another. So it causes a problem. Children who have been sexually abused also have this type thing. Of course, again, that can be trauma. So if you can get the trust of the child, a lot of times they will tell you what's going on. Sometimes the perpetrator may be an adult that's in their life that they trust. And if they're sexually acting out or doing things, like an 8-year-old knows how to have sex, that type thing, and demonstrates it, that is not normal. So those children need to have intensive psychotherapy. Okay, very important that we actually talk to the patient about the depression. They need the education. Many people think that, oh, I'm just depressed, it'll go away, which it really does not happen. They have to understand that it is a chemical imbalance in the brain. I think our society is starting to accept depression and anxiety more than they used to. Mental illness, I think, because of the advertising and the fact that some of the stars have actually started saying I'm bipolar or schizophrenic, those type things, it's become more socially acceptable. The problem that we find is because there have been centuries and millennia of people that were considered to be, quote, crazy, that sometimes they would chain them to the walls and dungeons and all kinds of stuff over the decades and, like I said, millennia. There's such a stigma there still that people will not seek help. So you're going to see them in the primary care setting. That is the main reason that we're doing this little webinar, because we want you to realize, if you haven't already seen people who are depressed or have anxiety or have other issues, post-traumatic stress disorder, you're going to see them in that situation, because they feel comfortable with the primary care provider. They've established usually a good relationship, and they feel safe coming to that type of setting. Whereas sometimes they are referred out, and many times they don't have the resources to especially the rural areas, don't have resources to go to that setting. So telehealth is becoming more and more available. So we'll see more of that for mental health. The other thing is, if somebody already is depressed and is on medications for depression, especially females, you want to find out what their thoughts on getting pregnant are, because that can affect the baby long term. So they would need to be going to a specialist. And then we have a thing called discontinuation syndrome. And people got to get tired of playing with their medicine. The SSR takes 3 to 5 weeks, sometimes longer, up to 2 months to actually work. And so people will look for alternatives. Sometimes they may even start doing drugs or taking somebody else's medication or that type of thing. But once they start taking an SSRI, you want to explain to them it's very important to continue taking that and do not just abruptly withdraw it, because they can have side effects. It's called discontinuation syndrome. And they can have vertigo, nausea, vomiting, nightmares, electric feelings in their head, and the depression may rebound. So very, very important that we educate the patients on what's going on with the medication and make sure that they understand that it's going to take a while. So usually what I do is I follow up with the person in 2 weeks, or I say to them, call us if you have problems, or go to the ER if you get suicidal. Suicidality is a problem when somebody's depressed. You should automatically flag that, as you need to assess them for that, for making sure they're not going to kill themselves today or tomorrow. Okay, so FDA warnings, especially kids or children under age 24, is that they may increase, after you start them on a medication, they may increase the risk of suicidality. Usually children, depending on the relationship they have with their provider or with their parents, may or may not come forth and tell you that. Also, we have seen a lot of, we don't want to call them cults, we'll say little groups of kids who have made pacts that they're going to kill themselves. And so maybe 5 or 6 kids that know each other kill themselves. So be aware that that is also around. But once the medication is started, it's very important, number one, that the mother, father, whoever, significant other, who is managing the child, make sure that they take their medication daily, and that any symptoms related to suicide are evaluated. Okay, so sometimes it's better to just not give children medication. I have seen children on medication as early as 3 years old, not for suicidality or not for depression, but for other things like ADHD, which that child really needed it. I can tell you that for sure. But we need to be careful when we start giving medications to children. And those actually, they need to go to a pediatric psychiatrist or psychologist to be managed that way. But they can always go into play therapy or any other type of therapy where they can act out how they feel. And sometimes you get some big time revelations, such as maybe they're being sexually abused, because they will do that in play, because play is a very safe place. That's what children do. They like to play, and that's how they learn and grow. So play therapy is a very special type of counseling for children, but it is very effective. Okay, again, when somebody becomes pregnant or plans to become pregnant, they need to go to somebody who's OBGYN psych. A lot of times the OBGYNs will manage their own patients, and they have either the psych degree or they have been trained in it. So it's very important that we do not manage these people in the primary care settings. Most people will go to their OBGYN anyway, because most primary care providers do not offer pregnancy screening and all that for long term. They'll usually send the patient out to somebody else. So anybody who appears to want to be pregnant and you know that they're on antidepressants, they need to go for a full psych evaluation. We need to make sure that both patient and the baby are safe. So this is why they need to go to a specialist. And then we have a thing called neonatal abstinence syndrome, and that basically is kind of relates to almost any kind of medication. A lot of times the female may be taking meth or something like that, or doing heroin or something like that. So when they give birth, they may be given birth in a special hospital or be sent to a special hospital with the baby, because they go into neonatal abstinence syndrome. And basically it's basically a withdrawal from any medication. So it's very important that we're very aware of this situation and that we make sure that the patient gets the care that they need. And again, a specialist is really required in that situation. Okay, so when we look at depression, we have to think about, how do we treat the patient? Are they at suicidal risk? That is really going to be the main thing we're looking at. Are they suicidal? Is their judgment impaired? Did they have a support system? Are they into substance abuse? Do they have other psych disorders? You're going to find in the psych world that people do what they call self-medicate. So let's say that Joe Blow has depression, but he drinks a fifth of whiskey every other day to manage it, or he may drink 10 beers a night or something like that. That is called a problem, because what you're doing is, not only do you have a problem of initial depression, you have substance abuse. So we look closely at those patients and screen them for the substance abuse and also additional psych disorders. There's a lot of times you're going to find in the psychiatric population, they may have a lot of psychiatric comorbidities. Okay, so if somebody is really, really suicidal, they tell you they're going to kill themselves, they have a plan, that, as Dr. Goddard indicated earlier, get them to the ER. Okay, or MHMR is very, very effective, and their job is to place these people, and they can usually sometimes get them into a psych facility almost immediately. So they are a very good resource. And usually, if they have no resources, they end up in the state facility so that they can be managed appropriately. So if they've never been depressed before and all of a sudden they're depressed, we consider that acute. And you want to make sure that they're managed appropriately. Once they've been in the system a while, you're going to be managing these people 1 to 2 years out. Usually after 1 year of therapy and medication management, they should be stabilized and they may be able to come off some of the meds. But usually the research shows at least 1 year, sometimes 2 years for maintenance. We want to prevent reoccurrence or relapse. And so it's very important that we take time to carefully evaluate these people. And again, sometimes they may need a higher level of care. They may need a specialist. Okay. When we look at medication treatment, we need to look at side effects. Very, very important, especially since the 5-HT receptors are all through the GI tract or in the blood. They're everywhere in the body. And so a lot of patients cannot handle some of the side effects, especially males. If they get erectile dysfunction, they are not going to be compliant with medication. So when you're looking at males, you need to think about, okay, you need to talk to them about sex. How sexually active are you? Do you have a spouse? Blah, 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 or significant other or whatever. And, if they are young and male, I'm sure they're going to be having sex. So you need to talk to them about their sexual health and make sure that the medication that you give them is not going to cause ED, because they are not going to be compliant, because sex is a very big, important thing in many men's lives. I know it's important in women, but usually they don't have ED. So that one we kind of bypass. Lifestyle changes, diet, stress management are very important. A lot of times if people are eating a lot of junk food, that can also cause neurological changes because they're not getting the nutrition they need. Alcoholics are usually thiamine deficient. So there's a lot of other things that we need to check, again, to make sure that the patient is getting what they need. Stress management and spiritual issues. Sometimes patients will talk to you about that, sometimes not. I look at patients holistically. If they do have a belief system, then we do talk about that somewhat. But it's very important to make sure that you look at the patient holistically. And of course, therapy is very, very, very important. Cognitive behavioral therapy, even if somebody is just having a lot of bereavement, because we do have prolonged bereavement problems with a lot of people, cognitive behavioral therapy will help them think differently. Instead of being in the negative, it will help them think about things differently, because thinking is a learned behavior. A lot of times what people around us are thinking, and we learn their behavior, and sometimes we mimic it. So cognitive behavior, sometimes the family needs to be involved, especially in children. Group therapy can also be part of this situation, but success usually is with some type of therapy and medication management. Sometimes patients may just want to try the therapy first, which is very acceptable as long as they're not suicidal. Okay, so if we're looking at depression and anxiety kind of go along hand in hand. So just be aware that when you just screen someone for depression, you need to also screen them for anxiety. Okay, so a lot of times you might want to start a medicine that will deal with both, so that you can, instead of taking 2 pills, they take 1. Now, you always should start slow and go slow. Start low, go slow, especially elderly and children. Now, elderly, there's the Beers criteria. You always need to think about giving them half of what you normally give someone else, and I'm not going to go into that in detail, but the Beers criteria is very important, especially management of the elderly. Children, again, if you're trying to manage them in the clinic, it's going to be important that you do have somebody collaborating with you, such as a psych, pediatrician. So I would not try to manage a child as a primary care provider. I would not try to manage a child in that kind of thing unless I knew children. So it's very, very important that you know your patient population and you stay safe within that. And also, you're going to maximize the dose of the medication before you switch to another. So a lot of times the patient will try something for a month. That is not maximizing the dose, okay? So if you start something at half the dose, that's fine, because you want to go low and slow. But you have to realize at some point you have to up the medication if it's not working for the patient. So they need to be followed up in 1 to 2 weeks initially, and then maybe another 2 weeks. Just keep close tabs on them, because that first 30 to 60 days, they do have a risk for being suicidal. So you want to make sure that they are doing well, that they're going to counseling. And counseling is now online, so it should not be a detriment or a hindrance to getting counseling, especially with all the COVID stuff. Depending on the patient, if I think the patient is high risk, I may see them weekly or have them come every other day. Use those scales, those questionnaires that we talked about, that Dr. Goddard went through earlier. Okay. If they're pregnant, make sure that again, that they're referred out. If they have comorbidities, OCD, eating disorders, substance use, all that, they need to be referred out. Anything that's beyond just simple depression or anxiety needs to be referred out, especially if you can't see the patient on a regular basis, because you are not only risking your license and practice, but you're risking the patient, which is the most important thing. Okay, go on PowerPoint. There it goes. All right, so let's talk about the type of medications that we use. SSRIs are the first line, unless they have cardiac problems. So you should always work the patient up before you even start them on any medications. Again, we should be checking for B12, folate, check for thyroid, make sure they don't have any other type of disease that may interfere with that. And just do CBC, because anemia can cause tiredness and all this other stuff. So make sure they get a thorough workout, EKG, and we leave it at that. You need to always make sure that you're safe. The SNRI, and remember I discussed earlier that anhedonia is really more related to dopamine. So that when we look at the SNRI, we're looking at norepinephrine, which is a precursor to dopamine. And so we want to make sure that maybe we give them an SNRI instead of an SSRI, because we want to target what the symptoms are presenting as. And so another thing to remember is that TCAs, and I don't really care for TCAs, they are really bad for elderly people because they have a lot of anticholinergic side effects, and they're also cardiac issues that can revolve around that, so you have to stay away from that. And the QT interval, which tells you the time of polarization and depolarization in the patient, can increase. So very, very important that you really don't start anybody on a TCA now. Remeron, you can give that to somebody who's an adult for sleep and depression. That would work. But some of the others I would stay away from. So SSRI, again, is the first line. But if they do have cardiac problems, then we're going to look at different medications for them. Okay, remember that when somebody is already on a serotonin medication, you cannot add another serotonin medication. Okay, so these are some problems that we have. The drug interactions would be triptans, MAOIs, SNRIs, because again, you're still stimulating parts of that brain, tramadol, amphetamines, and if they're out there doing methamphetamines, we got problem. Bupropion, ecstasy, St. John's wort, which people don't think about, the herbals, ginseng, and nutmeg. And the problem is with serotonin syndrome is that the patient can actually die from that, so you really don't want to do that. Okay, because some examples of serotonin syndrome, first off, considered an emergency. Secondly, they may have confusion, hypomania, sweating, shivering, hallucinations. They may become extremely hypertensive and tachycardic. Okay, treatment is to be supportive with whatever they're representing as, but there is a drug called cypropheniramine, CYP, and this will be in your handouts, CYPROPHEPTADINE. It's off-label, and it would be given 12 milligrams as the initial dose, then 2 milligrams every 2 hours, or 48 milligrams every 6 hours. Do not give it if you do not feel qualified to give it. That might be something they need to do in the ER, because again, they're at risk, and you do not want them to die on you. If they come to you with a blood pressure that's stroke level, 250 over 120 or something, then you need to be getting them to the ER anyway. But if you recognize the fact that they, maybe you had started them on Prozac and somebody came along and gave them something for weight loss that was an amphetamine, it can cause a problem. So they need to be educated on making sure that they're not out there doing weird things. And if they really like nutmeg, it may be a problem, because you're going to have a drug-to-drug interaction and cause the serotonin syndrome to occur. And we really don't want to see that in the patients. Okay, so basically, I've kind of went over this a little bit, but again, SSRI, sexual dysfunction, very, very important. Restlessness, weight gain, Prozac won't cause that, but most of them will. Sweating, fatigue, lethargy, tremor, and serotonin syndrome. So just be aware that they're going to know that. And again, make sure that the patient is aware of the education related to sexual side effects, because that to them in general is very, very discouraging, and they're not going to be medication compliant. Okay, now we're going to talk, just hit a few drugs here. I'm not going to go into detail. Most of the drugs with the SSRIs, again, are going to act on the serotonin. Okay, Prozac is a good drug in the fact that it has a long half-life, so if the patient forgets to take their pills every day, then they still are going to have a decent level. Okay, again, 4 weeks to get to a steady state with the medication. And at the last time I looked, it was on the $4 list. Paxil. Now, the thing with Paxil, it is sedating, so you want to give it at bedtime, but it also has a very short half-life. So if you have somebody who is not medication compliant, not a good drug to give them. So I would always go err on the side of Prozac versus Paxil, because Paxil, they can get into discontinuation syndrome really easy because they are non-compliant, or their body may metabolize it really fast. It's already, like I said, a very short half-life. Zoloft has a slight dopamine effect, so you could maybe use that for those who have anhedonia. It may be better for people who have cardiac problems. It's also used for PTSD and the premenstrual dysphoric syndrome, OCD, and other things. Luvox is very sedating, and it may increase liver function tests. And there are many drug-to-drug interactions. I would stay away from Luvox for the most part, unless that might be a second or third line drug that might be tried. Okay. Celexa, we see this more used for an analgesic than anything else, I think, nowadays, but it can be something that we use. Especially if somebody has chronic pain, that would be a good drug to use, and you could manage it that way. The problem with Celexa is sometimes headache is like a major side effect for some people. And if they're on beta blockers or they have codeine in their system, it's going to interfere with that. Lexapro, I've seen this given a lot. Basically not a good drug for somebody who wants to get pregnant that's already on SSRIs. It can cause major issues in the first trimester of pregnancy. It's also approved for general anxiety disorder, panic disorder, and we can use this one in teenagers. Okay, some atypical antidepressants are like Wellbutrin. Now, Wellbutrin a lot of times is one of the drugs that you can see given in males, because the side effect of sexual dysfunction is not usually there. Okay, there is a risk of seizures. There's no weight gain. If they have an eating disorder or they have seizures, this is not the drug to give them. And they cannot use drugs, so they shouldn't be using drugs anyway, but like substance abuse, you don't want to see that, or alcohol. Okay, and it's best given in the morning. And they should avoid caffeine. So there's no drug that's going to be perfect. You're going to find that every drug has something that is not going to be desirable. But sometimes we have to choose the lesser of two evils to make sure that we get the best patient medication and treatment for the situation. Okay, now Effexor is the best SNRI to use if you have the, again, anhedonia with the patients. You can get started at low doses. Okay. The problem is it can raise the blood pressure. So if someone already has hypertension, I would not be using it. And if you cannot trust the patient to take their meds as ordered, I would not give it to them, because if they decide that they're suicidal one day and they have decided that that's going to be the drug they take, and they overdose, they have an increased risk of really dying. And then we have cardiac side effects, the QT prolongation, tachycardia. Then when you think norepinephrine, think dopamine, because those are the things that really can affect the heart. Cymbalta is another atypical to SNRI. Again, it can increase the liver function test. It does have a 12-hour half-life, which can be good or not good, depending on the patient. I would have them take it at night because it can be sedating, and so by the time they wake up in the morning, that sedation should be going away, and then it can cause constipation. This particular medication is given for fibromyalgia, GAD, neuropathy, chronic pain. So again, if the person has some of these issues like neuropathy or chronic pain or that type of thing, it may be very beneficial for them. Now, you're not going to see Prestique usually given in the primary care setting. Again, these drugs are going to increase blood pressure. If you ever work critical care, you're going to realize that, or ER or any of those places, dopamine, that's what it does, okay? Now, it may have a lower incidence of sexual side effects. You cannot use it with any type of anticoagulant like Coumadin, aspirin, or NSAIDs.